ערב טוב לכולם, good evening everyone. מדבר דוקטור נגב בר, מיושב ראש החברה לרפואת שריר ושלד. אני שמח שכולכם הצטרפתם לאקדמיה לרפואת שריר ושלד. יש לנו את הוובינר של פרופסור מייקל קוצ'רה, ברשותכם, שתי מילים באנגלית. Good evening everyone. This is Dr. Negev Bar, the chairman of the Israel Society of Musculoskeletal Medicine. I'm happy to introduce, to invite Professor Michael Kuchera to give this webinar. Let me say a few more words in Hebrew, and then we'll go back to English to Dr. Simon Wolfson. יש לנו מעל 200 נרשמים לוובינר הזה, והוובינר הזה זה הוובינר מספר 4 שלנו. אנחנו משדרים אותו מארצות הברית עם פרופסור מייקל קוצ'רה. הוובינר הזה, כמו שדוקטור סיימון יספר לכם, הוא המבוא לקורס שפרופסור מייקל קוצ'רה ייתן במרץ 2019. אני אעביר את המילים לדוקטור סיימון וולפסון ביוונית.
I'm very proud to present Professor Michael Kuchera, personal friend of mine and colleague for quite a few years. Mike is a professor of osteopathic medicine, doctor of osteopathy. He's a professor and chairperson of the Department of Osteopathic Manual Medicine at the newly proposed Minnesota College of Osteopathic Medicine. He's also the Secretary General of the Federation, the International Federation of Musculoskeletal Medicine. This webinar that Mike will give is actually a short teaser for the course that Mike will be showing in presenting here in Tel Aviv area in March, and you can already save the dates. If you want to see, you can see on your screen, 27th to 29th of March will be a 3-day program. 31st to the 2nd of April will be a second program. Just before we go over to Mike, I want to mention that a couple of things. If you go into our website, you'll see that there's a basic dry needling course taking place both in the Safarov Fair and in Rambam, October and November 2018. There's an advanced dry needling course taking place on the upper body in December 2018. The workshop, as I mentioned before, with Mike Kuchera. This, for those of you who see it in Hebrew, this is a basic course, over November 2018. And the advanced course, December 2018, all the information is on our website. So without further ado, very, very happy to have Professor Mike Kuchera with us, and over to you, Mike, and let's hope we have a really good webinar. Bye.
Hello, everyone.
Go ahead.
I'm looking forward over this next hour to spending some time with you, taking a look at counterstrain and doing so from theory to practice. In our discussions today, I'm going to try to focus how counterstrain might be used in chronic central pain conditions, and in this fashion give you an opportunity not only to think about new techniques, but how they can be applied clinically. And I think this is a wonderful opportunity for our two societies, the Israeli Society of Musculoskeletal Medicine and the American Academy of Osteopathy, to work together. You in touching the pain, and we in looking at physician-integrated approaches to manual medicine. In our webinar today, I'm hoping to go from theory about counterstrain and discuss the evolving evidence base and the parts that are able to be applied in manual medicine approaches. In particular, I wanted to touch briefly on tensegrity and make a short discussion of the mechanotransduction research that has us now thinking about using this technique for reducing inflammation, reducing pain, improving function, and enhancing homeostasis. And depending on our time together and how many questions there are, I might want to foreshadow some additional theory to practice insights dealing with chronic pain syndromes. In particular, I was hoping to touch upon polyvagal technique. Techniques by themselves are for therapists. Physicians would like to take our techniques and integrate them into practice. The more we know about how the techniques work, the better we're able to understand the indications and contraindications. Today, I'm going to focus on touching upon chronic pain syndromes. because particularly when they're tied to central sensitization and dysautonomia, these are very difficult to manage clinically. Manual medicine, I have found in my practice, has enabled me to touch the pain and to touch the patient in a fashion which allows them greater improvement in quality of life, as well as more lasting treatment protocols. In this webinar, I'm going to discuss just an osteopathic manual technique known as strain counterstrain, and how it might be used to implement some of the strategies for chronic centralized pain syndromes, using fibromyalgia syndrome as the main exemplar. Hopefully by the end of this webinar, the regimen that you'll be able to adopt for your patients will be through improved abilities and improved judgment. And if you're interested, then our hands-on courses in March will be an opportunity to better apply and learn how to use counterstrain and also muscle energy techniques. These will be a part of our 2 programs. I suppose at this point I should ask, are there any questions or any perceptions before we move on to our clinical introduction?
Okay, Mike. So at the moment, I don't see any questions yet. I think you can continue as you are.
All right. Let's briefly go through pain continuum and talk about chronic central pain syndromes. This comes from an article by Arnold on fibromyalgia and chronic pain syndromes that was published recently in the Clinical Journal of Pain. As you know, there's a pain continuum running from nociceptive to neuropathic to centralized pain. Nociceptive pain we recognize as the types of pain where we have damage in the somatic or the visceral tissues due to trauma or inflammation. Neuropathic pain, and here are some examples, would be related to the damage of the peripheral or the central nerves. Today we're going to focus on, oops, let me go back a slide here. I'm going forward, I want to go backwards. There we are. Today we're going to focus primarily on pain without identifiable nerve or tissue damage. This is thought to result from persistent neuronal dysregulation. And so the centralized pain, we'll talk about fibromyalgia syndrome. Other examples include temporomandibular joint dysfunction syndromes, irritable bowel syndrome, etc. When we talk about chronic central pain, 2 of the most commonly used terms in the pain world are hyperalgesia and allodynia. In allodynia, we're talking about a painful response to something that is normally innocuous in its stimulation. So for instance, here in fibromyalgia patients, if we take a look at a stimulus intensity across the bottom and a pain intensity across the top, often the amount of stimulus intensity needed for the patient to register pain, as shown along this red line, might be around 4 kilograms. Whereas if you have a patient who has fibromyalgia, something maybe down in the area of 2 kilograms or 2¼ kilograms might initiate the same amount of pain that someone else experiences. Allodynia and the centralized sensitization, which increases the response to a painful stimulus, hyperalgesia, are both seen in central pain syndromes. What we'll be doing is looking at different goals to decrease afferent drive by reducing inflammation and dysfunction in the periphery, as well as ways in which we might decrease the central sensitization in the brain or in the spinal area. In the spinal area, we often, in our profession, call this segmental facilitation. Segmental facilitation is an irritable focus in the spinal cord itself, usually in the dorsal horn. Afferent information from somatic tissues or from visceral tissues feed in, and they decrease the amount of other stimulation that would need to fire the area off. These areas act as neurologic lenses. As a neurologic lens, any painful or visceral or even emotional activity can fire the area off and have consequences through the autonomics in particular, from the spinal cord T1 to L2, will have a sympathetic response with characteristic changes in the spinal tissues, paraspinal muscles, and into various organs that are at the same segmental levels. So for instance, at the thoracolumbar junction, you may find that dysfunction or inflammation or afferent information from the somatic system may feed into the gut and lead to irritable bowel symptoms such as constipation or other sympathetic changes in the respective organ systems. Outside of the spinal cord, in the brain region, we have central sensitization that can affect the parasympathetics through cranial nerves 3, 7, 9, and 10, as well as through information coming in from the pelvic splanchnics that can affect the parasympathetics to the pelvic organs. We'll talk a little bit later, if we have time, about central sensitization and its effect on the vagus. However, for the bulk of this program, we're going to take a look at decreasing afferent information from the peripheral tissues and decreasing spinal segmental facilitation centrally. So in taking a look at how we might do this, today I wanted to focus on, from theory to practice, on the technique called counterstrain. And I'd like to talk a little bit about how it's been thought of in the past and currently, and how we might be thinking of it in the future. Counterstrain was originally called spontaneous release by positioning. And there's a variation of positional releases called facilitated positional release, which I'll mention a little bit today. The history of counterstrain or spontaneous release by positioning goes back to the 1950s. An osteopathic physician by the name of Larry Jones had a difficult patient. The patient came in, had seen orthopedic surgeons, it had seen chiropractors, he had seen all sorts of individuals, and was not able to obtain relief. Dr. Jones did what he normally did with patients and was able to get some results, but nothing that was lasting. And so finally, in frustration, he and the patient decided together if he could only find a comfortable position in which to sleep, he would be a happy camper. So Dr. Jones put him on the table, propped him up with some pillows underneath his legs, and finally found a position where the patient's pain went away. The patient was so comfortable, he fell asleep, and Dr. Jones went and saw the patient next door. When he returned, the patient was still asleep. Dr. Jones gently awakened him, and so as not to startle him, said, let's get you out of this position. So he removed the pillows and he slowly put the patient's legs back down, rolled them onto their side and sat them up and said, now, will you be able to find this position again so that you can get some sleep? The patient said, wow, not only that, but my pain's gone. And this spontaneous release of pain and dysfunction by positioning was something that Larry Jones then developed over many more years into a very thoughtful system that can be applied to muscles, to joints, basically to any tissues, somatic tissues of the body. Counterstrain today is very commonly used. An osteopathic survey in the United States conducted in 1998 suggested that about 85% of the physicians in our country who do manual medicine use counterstrain as a part of their manual technique armamentarium. It's actually the fourth most commonly used manual medicine technique. It's very easy to teach. The setup is basically the opposite of what you would do to stretch a muscle. If the problem is in a myofascial tissue, instead of stretching origin to insertion, you shorten the tissues and you find an area where the pain is reduced. In this case, then, you can use palpation to find an area that is very loose and very non-tight. But the interesting thing is the patient will tell you, yes, my pain is going down, it's going down. And when you find the least amount of discomfort when you press on the point, then you've found the correct position in which to apply strain, counter-strain technique. And we've done
Mike, can I?
Yes.
Good. Can I ask you a question here? And also I'd like to, at the same point, point out to our attendees that any question that you have, you can send me just by clicking on the questions and typing in your question in English and Hebrew. If it's in Hebrew, I'll translate it into English. And if it's in English, obviously straight away. But what I want to ask you, Mike, is you're saying this is a simple technique that is easily learned by anybody who's got a basic knowledge of healing and so on. So a family doctor who's interested in learning, let's say, just the counter-strain technique as one technique that he can use easily for his patients who he sees are in pain, this is something he can learn as a standalone, and he doesn't have to go through intensive training in order to be able to use this technique safely?
Yes, it's a very nice technique for those who have not had palpatory diagnosis and treatment in a manual medicine setting before. If you have an understanding of anatomy, it makes the technique go a lot faster, but basically you're going to use a rubric where you find the point that is tender, you position the patient in a position that at least 70% of the pain goes away, and you just hold them there in that position for 90 seconds and then slowly return them. And so as a primary care doctor, you can learn to apply this in myofascial trigger points or areas where the patient says, you know, I have a headache. And the better you understand what structures might refer pain in what area, the better you know where to look for a problem. But once you find it, the technique, as you say, is very simple to apply. So I'll try not to jump next time that Simon asks a question. And I'll talk a little bit about some of the research that's been done in vivo and in vitro for applying this technique. As I say, if you find an area, for instance, this can be used for rib dysfunction, or it can be used for some of the muscles of the chest wall. But say you find a point here that is quite tender. You would tell the patient that's $1 worth of pain, something that's worth 100 of something, €1, $1, 100. I try not to use a scale of 10 because most patients who have chronic pain have already been instructed to say that the worst pain that you can imagine is a 10. And so when you tell somebody that that's a 10, they'll say, no, it isn't. It's a 3, it's a 4. Well, I don't want that. I want to be able to reduce the pain by 70%. So I'm going to go ahead and tell the patient that it's worth $1 of tenderness. And then I'll go ahead and I'll forward or backward bend the patient, side bend the patient, rotate the patient. I'll position the patient so that the spot when I push on it is at least 70% reduced. It'll also have the loosest feel. So when you get good at this, you won't even necessarily have to ask the patient. But as you get started, it's a way of getting good feedback about whether you're in the right spot or not. Once you get to the position where it's at least 70% reduced, then you're going to monitor and keep your finger on that point and just hold them in that position for 90 seconds with the patient relaxed. Every once in a while, go back and push on the point and see if it's still less than 30 cents of residual pain, and see if there's any tension that has taken place. At the end of 90 seconds, tell the patient, just relax, let me do all the work. And you slowly, and they are passively, you slowly return them to a resting position. This allows you to reset the muscles without the patient or their central nervous system guarding. With your finger still on the point, now go ahead and push it again and say, if it was $1 before, what is it now? And the patient will say, well, actually, it's totally gone, or it's 10 cents. The dramatic reduction of pain is something that you can expect. If it should be more than 30 cents still remaining, you probably need to look for a different muscle first and then come back to this one. You probably didn't get something in the right order. It's important that you don't remove the finger during your treatment. And this is because if you take the finger off, reposition the patient, and then go back to recheck, the patient will say, well, yes, it's totally gone, but you're not pushing in the same place. You want to leave your finger there. So one, you know that the treatment was effective, and perhaps as importantly or more so, the patient knows that the treatment has worked. As I say, this can be used for multiple structures. For muscles, we often will use it by shortening the muscle. And this spontaneous release by positioning is something that if this represents the muscle that has a dysfunction, and we have an origin and an insertion, what you can do is you can shorten the muscle. That will take some of the afferent information off the muscle spindle. As you take the muscle afferent information off the spindle, the response is, I don't need to guard to protect the muscle, and you change the gamma gain in the muscle. So shorten the muscle, hold it for 90 seconds, and at the end of that 90 seconds, you can now go ahead and lengthen the muscle back towards its resting position. It's kind of interesting too, as you shorten this muscle, the muscle that has dysfunction, you will be stretching its antagonist. When you stretch the antagonist, that slight stretch also further relaxes the muscle. So you get some agonist-antagonist involvement. And then finally, the key after this muscle has relaxed is to return it passively to its normal length in a slow fashion. And basically, as you take that muscle, which had been tight because it needed to protect itself, and you slowly return it back to its normal position, the central nervous system says, well, yeah, that's fine, that length is fine, that length is fine. So that when you're finally done, you've reset the muscle to its normal resting length without any problem. This resetting of the gamma gain of the muscle spindle is the therapeutic action. So I'd like to kind of go through some examples
two
together.
Questions have come in, if I can stop you just here. The first question is from Simeon Asher, who's a very well-known osteopath in Israel, and he asks, how many spinal segments does the positional release affect according to research? Have we got any information about that?
Yes, it depends on the structure that you're treating. If, for instance, you're treating a spinal segment, a little bit later on we'll talk about treatment of something like C4 or C5, and you're positioning the facets, then the treatment will treat the one facet that, or the one segment that's involved. Obviously, if it's a group curve and that's the key lesion, you might affect segments that are reacting to it, but it's aimed at the one segment that you're treating. On the other hand, if you're treating something as we have here, we're going to use as an example the sternocleidomastoid muscle. Here, this spans several segments. And by treating this muscle, you may not only treat the muscle and remove dysfunction, but you may treat multiple spinal segments and multiple areas that are reacting to that muscle.
Second question that Simeon asked, thank you, is how long does this effect last, and do you need to repeat this treatment, and if so, how often? Are there any guidelines behind this?
As with most somatic dysfunction, if this was obtained as a consequence of a sudden move, or often what happens, for instance, is someone falls asleep in a easy chair, and then the phone rings and they jump up and they quickly stretch the muscle when it wasn't prepared. That will cause dysfunction, for instance, in the psoas. This might also happen as the patient is bent over in the garden for a long period of time and then stands up suddenly. So that sudden change that sets up the dysfunction, once you do the counterstrain technique and you repair the relationship between the peripheral muscle input and the central nervous system response to it, then your technique is done and the dysfunction remains removed. If, on the other hand, the problem was due, say, to multiple muscles in a postural imbalance situation, you can treat all of the muscles that you want. The patient will feel better, but if you didn't treat the underlying postural imbalance, everything will return. So in that sense, it's not different than other techniques.
Okay, thank you.
All right. So let's kind of think together. So if you've fallen asleep to my lulling dulcet tones here, wake up for just a second and let's kind of think about how we might treat the sternocleidomastoid muscle using counterstrain. Again, we're going to assign $1 worth of pain to a point. That can be anywhere in either of the two heads of the muscle. Here is the sternal head. Here is the clavicular head and the sternocleidomastoid. These are going to be the three areas that you could palpate, or you could palpate somewhere along the muscle. It doesn't matter, okay? Whatever is most tender. How do we treat it? Well, we're going to shorten the muscle. So if, for instance, the pain was here at the sternal attachment, that's $1 worth of pain. Okay, let's go ahead and start the technique. To approximate and shorten this muscle, we need to bring the mastoid closer to its sternal attachment. The mastoid's in the back of the head. The sternal portion is towards the front of the body. So if I would forward bend the head, I would move the mastoid process closer to the sternal area. Likewise, if I turn the head away from the point, here the point is on the right side. So if I turn the patient's head to the left, the mastoid process will also move closer to the front of the body. So forward bending with rotation away from the point would bring the mastoid closer to the sternal attachment. It would also bring it closer to the clavicular attachment, again, because the clavicle's in front of the mastoid process. So both of these heads of the muscle will benefit from flexion and from rotation of the head away from the point. The difference will be in side bending. In side bending for the clavicular end, you're going to want to have the patient side bend to the left, and that's because the sternal end is more medial. And so by side bending to the left, you bring this point back over the sternal end. Whereas with the mastoid process relative to the clavicular end, you're going to leave it fairly neutral, or maybe even side bend a little bit to the same side as the point. Okay? And so you'll see when and if you ever purchase a textbook on counterstrain, you'll see these little formulas. And the formulas will be for the sternal head, what Dr. Jones called the anterior 8th cervical region point. You would flex the patient, you would side bend away, you would rotate away. Whereas the clavicular end, which is the 7th point that Dr. Jones described, so anterior 7th cervical, you still would flex, you would still rotate away, but you would side bend towards. So this is one way in which then the patient, this is $1 worth of pain, flex the head, side bend toward or away, whatever brings this point closer together, and rotate the head away. Now what is it? And the patient might say, well, now it's 40 cents. Okay, let's add a little bit more flexion and maybe a little bit more rotation. Oh, that's 20 cents. Well, I'm a perfectionist. Let's see if we can get a little bit better. I'll add a little side bending one direction. Oh, that went up to 30. Whoop, and I'll go back the other way. Oh, that went down to 10, or that's perfect. Okay, just let your head be heavy. Let me hold it here. Just relax, and you'll watch for 90 seconds. At the end of 90 seconds, tell the patient, okay, just relax, let me do all the work. Slowly bring the head down, slowly derotate it, and then with the fingers still there, push on it again. If it was $1 before, what is it now? It's gone. It's 10 cents. You're fine then. So that's an example of the treatment.
Okay. So Dr. Jakob Vogelman asked us a question. He says he can understand, it's quite intuitive for him to understand how to work, for example, on the sternocleidomastoid or other muscles of the neck. And he could feel quite comfortable with that. But what would you do, for example, with intercostal muscles, that area where you think that the patient has got myofascial tension or whatever, less counterintuitive to work on that area? And are there specific techniques that you can learn to work, for example, on intercostal muscles?
Yes, intercostal muscles, as well as rib dysfunction themselves. The ribs themselves may have a pump handle or a bucket bale component, meaning when you take a breath in, they move up in front, back, down, and behind, or on the sides, they may move up during inhalation or down during exhalation. If the dysfunction involved those muscles or a rib in that fashion, you could bend forward. Bending forward would bring the rib down in front. You could side bend to the side of that rib. That would bring the rib down in the bucket bale component on that side. Conversely, it would be bringing the other side up. So the positions for side bending and flexion or extension would help to position those ribs. And then
Wonderful.
Usually for the muscles, a rotation component into the point usually is successful in decreasing the pain.
And then Rinat asks us, also one of our followers who's been working with us on studied osteopathic medicine in Israel. She asks us, if we've worked on a point and you haven't really had very much success, hasn't really helped, so should you repeat it, or should you think, well, we're probably not on the right muscle or the right positioning, and let's go to something else? Would you expect the positioning to work if you're in the right place?
The majority of patients, if you're in the right place and you position correctly, it will work. Sometimes there are patterns of muscles where getting them to the right position for the muscle that you intend to treat puts them at such discomfort at some other site that you'll have to treat that site first. Or sometimes there may be a type of dysfunction that doesn't lend itself to positioning, that you might have to prepare the tissues first with a different technique. But that's very uncommon. Typically, counterstrain will work for you.
Okay, so I'm going to ask one more question. I see that our group are really interested here. And from this, I can really understand that we're going to have a great turnout when you arrive here in March. But the question is from Nachman, and he says, is the technique relevant only when we're talking about a constant pain that occurs or exists with the patient when he's at rest, or can we talk about pain that occurs with different attacks or so on? Is it only constant pain, or any of the muscular or joint pains?
No, actually, it's kind of interesting. If you take a good history, you may find people who say, well, yes, I've got a lot of back pain. And then when you ask about the history, you find out that it was they were in a position where they were forward bent to begin with during the process where they injured themselves, a car accident or a process of working in the garden. In those cases, the points are usually on the shortened side. So often you'll find a point in the front that the patient never knew hurt, but it is causing the dysfunction throughout the body. So it could be at the site of pain, it could be at the site of a historical cause of referred pain. This lends itself nicely to, for instance, myofascial pain and dysfunction in the Trebellin-Simons style as well.
Okay, thanks a lot. So I'm going to stop. There are more questions, but we're going to let you get back to work a little bit, and I'll bring them in a little bit later.
And this might be a little bit helpful. I'm going to mention a little on tensegrity, and we understand macro tensegrity, and I think we all understand muscle spindles and gamma gain. But I think you might be interested in some of the micro tensegrity theory. So here's the macro tensegrity, the stuff that is involved with muscle imbalance. And if you've got a tight muscle, counterstrain makes a lot of sense, of course, because it through the muscle spindle activity that I told you about, you can go ahead and return function to that muscle. Likewise, if we think about tensegrity of the body, if we have tight muscle in one particular area, the concept of tensegrity is that you've got rigid areas that are suspended in relationship to one another through various tensions in elastic elements. And when one elastic element is too tight or too loose, it changes the tension throughout the entire structure. So macro tensegrity is something that most manual physicians understand very well for the role of posture in causing pains that might be distant, or in postural and or tonic phasic muscles here in the lower crossed or the upper crossed syndromes that Yanda and Levitt talked about. You can have this macro tensegrity take place. And treatment with counterstrain or any other technique that helps with one area of the body may have an effect on all. But let's talk a little bit about the theory, the new information that's coming from the concept of microtensegrity. And Ingber has done a good job out of Harvard talking about this. This was a topic that was presented at the International Fascial Research Congress back in 2009. And the concept here is that you can have tensegrity down to the cellular level. So here's a cell, for instance, and connected to it will be all sorts of myofascial strands, and these myofascial strands connect into integrins in the cell body. The integrins in the cell body are very interesting because they're subject to mechanotransduction. They're mechanoreceptor elements, so that if you should put a pull into an integrin in the right direction with the right amount of force, you can actually change what happens in structures within the cell. So for instance, if this structure takes substance 1 and turns it into a different substance, number 2, at a particular rate, as you balance the tension in certain microfilaments and compression in other microfilaments within the cell, with a pull or with a mechanical activation into the integrin, you can change the production of that structure. And instead of making maybe a 1-to-1 rate, you might upregulate a massive production of something out of this. And if you would put the same amount of force into something at a non-integrin area, you don't get the same result. You only get it when you're at these integrins. So these mechanical stimuli of adding tension or reducing tension into an integrin can change a biomechanical force into a biochemical reaction. That's called mechanotransduction. The mechanotransduction was studied by Dr. Stanley out of the University of Arizona. and he had worked originally with the Arizona Osteopathic School. And what they did is they took fibroblasts and they plated them on agar. And these fibroblasts then they subjected to a repetitive motion activity. And basically for 24 hours, for 8 hours, they went ahead and applied a mechanical force. We don't have 8 hours, so I'm going to stop the hands position. But at the end of the 8 hours, they took a look at the tissues. These are the tissues after repetitive motion strain for 8 hours. And they noticed that they were starting to get some increase. Anything that's in red is a 2 times increase in certain pro-inflammatory interleukins. Okay. Now, they watched that tissue for the next 24 hours. And as you can see, over 24 hours, there was a dramatic increase in the number of interleukins associated with inflammation. And there was also a lot of cell apoptosis or cell death. Okay. Now they decided, okay, let's take these fibroblasts, and instead of straining them, let's go ahead and just shorten them like we would do for counter strain. Let's shorten the tissues, take the stress off of them. And they did that, and they watched it for 24 hours. And as you might suspect, with no strain and with this very simple technique, nothing really changed. However, if you went ahead and you took those tissues and you did, again, the same 8 hours worth of stress, and immediately at the end of the 8 hours, shortened the tissues so that you did a simulated counter strain position and watched it for 24 hours, the counter strain aborted the inflammatory response. Counter strain not only is useful in reducing pain and changing muscle length and structure, but it also works at a cellular level in decreasing cell apoptosis and decreasing inflammatory responses. Counter strain is basically an anti-inflammatory approach. Isn't that interesting?
So it is. So we have a question here just about that. So Cecilia is asking, can we add light pressure after positioning and put our patient into an easy position, and that should, after we've done whatever treatment we have, and that should also help towards the end of the treatment session, whatever it might be. Would this be possible?
They've done this study. This classic study was done in 2007. Since that time, they've looked at simulated myofascial release and various other techniques. They've titrated it as to time and as to amount of pressure. And so in a cellular setting, in a in vitro setting, the amount of mechanical change does have an impact. Now, we're not treating cells that are on agar. We're treating real people. And so in way of answering your question, I'll mention that at the Ohio Heritage College of Osteopathic Medicine, John Howell did a series of experiments in which he looked at creating inflammatory response using eccentric exercises. And so with an arm, they did one set of eccentric exercises, and then they did eccentric exercises on the other side. As you know, with eccentric exercise, a lot of times you'll get post-exercise muscle soreness. Mm-hmm. Well, what they did is they applied counter strain at the end of the eccentric exercises to one arm, but not to the other. And interestingly, and consistent with what Stanley showed with the fibroblasts, if you added the you added the counter strain at the end of an eccentric exercise, it aborted the inflammatory response that was associated with post-exercise muscle soreness.
Well, that's very interesting.
Yeah, so I think
people in gyms, they do really hard work, and they do a lot of eccentric exercise in order to increase muscle strength and so on. And then they're always told, go and stretch your muscles afterwards. Nobody tells them, go and shorten your muscles afterwards.
Well,
interesting.
Well, and I think that if we take a look at the different types of techniques, there are different ways of activating and deactivating these mechanoreceptors. And so we have now been able in vitro and in vivo to look at counterstrain. As we take a look at further studies down the line, then a more precise answer for, if you position this way or you stretch that way, what's the best length, what's the best position? Those are things that we may be able to answer. Until then, let's keep doing what we do that helps the patient to recognize that they feel better.
Okay, so I just want to make one comment to our attendees. There are a few more questions that have been asked, but I don't think that we're going to get to them all. For the sake of time, I'm going to allow Mike to continue now uninterrupted unless there's anything super, super important to ask. There are a few more questions. It depends how much time Mike has for us, basically, but time is moving on. So I'm not going to ask all the other questions. There are quite a few others.
Okay, and I'll try to then shorten some of the exemplars so we get to the end in a timely fashion. So I might suggest that counterstrain indications for joint dysfunction, it can be joint or a somatic dysfunction of the myofascial systems, for overuse or repetitive strain. It's especially useful if they have acute pain because it moves the patient away from the painful direction. And it's good for anything with acute pain that has inflammation. Muscle pain syndromes, trigger points, chronic pain syndromes, and we're going to talk about fibromyalgia in particular. And basically, I see that you do a lot of dry needling. About anything that you did with a dry needle, you could potentially. All right. I'm going to skip this slide, which is facilitated positional release. It's basically something that was developed by Stan Shiowitz, and it's sometimes called fast counterstrain. Dr. Shiowitz was a physician from New York, and when he was learning counterstrain, he said, 90 seconds, oh my gosh, I'm from New York, I don't wait 90 seconds for anybody. And so what he did is he added a compressive component to the tissues, and it enabled him to be able to get the counterstrain activity done in basically 5 seconds. Part of what we'll do in our laboratory in March, if you should come, is talk a little bit about facilitated positional release as it compares to the positions for spontaneous release by positioning. In applying this, now you know how to do the technique, I'd like to again go back to this fibromyalgia and chronic pain syndrome paper and talk a little bit about some of the perspectives of change. We see in a lot of the central pain syndromes dysautonomia. And so whether it's fibromyalgia syndrome or myofascial pain syndrome, chronic fatigue syndrome, restless legs, so on and so forth, there's a whole series of conditions that have chronic central pain as a portion of it. For fibromyalgia, we see diffuse widespread pain lasting for at least 3 months. The new guidelines, 2010 and the 2016 modification, has moved us from what used to be you needed a diagnosis of 11 out of 18 points. The American College of Rheumatologists had used that more as a research definition than as a pragmatic definition. And to save time, you can look at your own studies for fibromyalgia or review this PowerPoint later. But I wanted to make the point that this diffuse widespread pain, you can treat points locally, but it's also helpful if you can use strategies that deal with dysautonomia, which we'll talk about at the very end of this presentation. I use a mnemonic, woke up stiff. That's widespread pain for the W. And then each pair at the occiput, at the knee, at the epicondyle, the upper outer quadrant of the buttock, peristernal next to about rib 2, supraspinatus, trapezius, the intertransverse space at C5, the femoral greater trochanter. All of these things, as I mentioned with the 4 kilogram, would cause pain with under 4 kilograms of pressure. And if we see this in 4 out of 5 areas, that's in the new guidelines, or 11 out of 18 or more points out of the 18 points, this was consistent with fibromyalgia diagnostics. When we look at fibromyalgia syndrome, it's about 2% of the general population between fibromyalgia and chronic fatigue. Interestingly, if you look at dysautonomia things like irritable bowel syndrome, in the general population, irritable bowel syndrome is about 10% of the population. But in patients who have fibromyalgia syndrome, it's a 6 times incidence. They have 60% of the fibromyalgia patients also have irritable bowel. 3 times as much dysmenorrhea, 15 times as much restless legs, 10 times as many chronic headaches, 5 times as many temporomandibular joint problems, 30 times as many bladder and irritable bladder types of symptoms. So dysautonomia is something that we see a lot in these chronic central pain syndromes, and modulating them can be through a reduction of inflammation and getting rid of some of this segmental facilitation and central facilitation. We did a study in the osteopathic profession. Actually, it's been probably 20 years ago now, and different schools use different forms of treatment. Kirksville used balanced ligamentous tension, Chicago used high velocity, the University of North Texas used counterstrain. And regardless of what techniques you use to remove dysfunction, about 90% of patients had an improvement in the quality of life. In addition, a certain percentage of these patients no longer fit the criteria for fibromyalgia syndrome as you removed things like somatic dysfunction. But I wanted to talk not about that as much as about the Texas protocol. Here they use medication, they used osteopathic treatment of counterstrain type primarily, and they taught the patients self-counterstrain. And what we know now in regard to the reduction of interleukins and inflammation wasn't known at that time. What they showed was that the best way of treating the patient was the combination of medication with the manual treatment of counterstrain, a little bit of myofascial release, some work at the base of the skull, soft tissue, and muscle energy. They treated the patient for somewhere between 15 to 30 minutes. And they empowered the patient to be able to treat themselves using counterstrain techniques. This was the most effective way of the patient managing their pain. Now, as we take a look at some of the examples, here are these 9 areas, each having a bilateral set of points. And I'd like to just use the trapezius, the lateral epicondyle, and the knee as an example of positioning using counterstrain. With the trapezius, for instance, somewhere in the muscle, usually about halfway down, is an area that is very common, not only in fibromyalgia patients, but in patients with headache. It's very common in tension type headaches. And I think you can see that if you wanted to go ahead and shorten the muscle, you would want to side bend the head towards the point. That would bring the attachment along at the base of the back of the head, closer to its attachment at the shoulder. You could also go ahead and rotate the head, depending on whether the fibers were in the back or the front. You could rotate toward or away. And this end, you could go ahead and lift the shoulder up and put a little traction in that direction, which would again shorten these fibers. And so the combination of what you'll see in, say, a counterstrain book would be to go ahead and flex slightly, side bend towards, pull the elbow up, add a little traction. You first say that's $1 worth of pain. You then position the patient. I like to do both things simultaneously. Hold it there for 90 seconds and then slowly return the patient to their resting position. Ask them again, where is it now? And quite commonly, this is gone. Their headaches go away, that particular point goes away, and they can use their shoulder better. The lateral epicondyle. Interestingly, with the lateral epicondyle, you have a whole series of muscles that attach to the lateral epicondyle. The lateral epicondyle is the attachment for the supinator muscle and also for the wrist extensors. And so if you've got lateral epicondylar pain, shortening the supinator, shortening the wrist extensors can go ahead and assume the counterstrain position. It's also interesting that pain from the Trabell system is referred into the lateral epicondyle from the anconeus and from the triceps. So if you would also add a little bit of extension to shorten the triceps, you may be able to go ahead and treat not only the lateral epicondylar point for fibromyalgia syndrome, but also for lateral epicondylitis. So here's the shortening of the muscles of the forearm using extension of the fingers and of the wrist. Likewise, you could go ahead and supinate the hand. And again, supination will shorten the supinator. And if you add a little bit of this combination of supination with wrist and finger extension and a little bit of a valgus stress, you will shorten all of the muscles that are associated with this region. And it can be very useful for tennis elbow, for instance, as well as for reducing one or two of the points that are associated with fibromyalgia syndrome. And the final one that I wanted to mention at this point in the grouping, and again in the course we'll work our way through each of these, but would be for things like the knee. The knee point is usually in the vastus medialis. In the vastus medialis, in order to shorten that muscle, if you place the leg on your knee and add an upward force, with a little downward force with your hands, you can hyperextend the knee. And then you pull or fold the vastus medialis muscle into the point of tension. So you say, here's $1 worth of pain, you monitor it, you hyperextend, fold things in. Now what is it? Hold it for 90 seconds and then return it back home. And these can be done for a number of the points. So at this point, counterstrain for fibromyalgia syndrome, you can go ahead and treat to reduce spinal facilitation, to reduce inflammation in these points. And it's only one type of condition where you might use counterstrain from theory to practice. So in finishing up, if I may, and then we can answer any questions you might have, I wanted to extrapolate a little bit away from counterstrain and go back to this concept of central sensitization on the vagus. Again, from theory to practice, one of the interesting theories that I've been using a lot in my chronic central pain patients is to take Stephen Porges' concepts of polyvagal theory. Polyvagal theory is a way of desensitizing, if you will, and modulating how the central response is to stress, to pain, to basically the allostatic load. His theory is a phylogenetic theory of the autonomic nervous system. He basically says if you look at evolution of the autonomic nervous system, we've got an old vagus that was good for resting and digesting. And if you take a central nervous system of a lizard and you stress that lizard, you know, oh, I'm going to be eaten, that lizard freezes. And freezing and pretending that you're dead and slowing all these functions wasn't a very effective stress modulator, but it's the way that the the lizards, if you will, responded to stress. That's an old vagus, an unmyelinated vagus, things that are primarily below the diaphragm. As evolutionarily or phylogenetically we progress, the mammals had the fight or flight system. And so the saber-toothed tiger is going to eat you. You modulate your sympathetics and parasympathetics. You shut down the parasympathetics. You don't need to rest and digest at this particular point. What you need is resources that are directed towards the muscles and towards vasoconstriction and towards things which help you to fight or flight. He also then goes and says, for humans, we've got a very advanced system. It's the myelinated vagus. This is the social engagement. When we are stressed, we express that on our face, and those muscles that are innervated by cranial nerves are engaged, and people who see us socially recognize what's going on in our face, and we exchange facial expressions, and our breathing modifies, and various anti-stress hormones are released, and this whole system of social engagement is something for the highest levels of healing in humans. And we have an interconnection between cranial nerves 5, 7, 9, 10, 11, and the phrenic nerve. And we're going to concentrate on the phrenic and cranial nerve 10. But his concept is, and we are seeing a lot of research with this in post-traumatic stress syndrome, is when our wounded warriors come back from war, if they don't have a social engagement system that helps them to start to heal, they revert to the fight or flight, and they become anxious, and they become stressed, and their blood pressure goes up. And if that system fails, then they revert to the old system, and they just freeze and can't function in our society. So the concepts of polyvagal theory, which is beyond what we're going to be discussing today, is something that I wanted to bring in and say how we can take a look at theories and apply them to practice. One of the things we can do, for instance, for afferent stimulation of stretch receptors, the alveoli themselves, when you bring air into your lungs and stretch those alveoli, that information is transmitted by the fast vagus up into the central system, and there's a phrenic response that goes along with it. And so there is a ability to use respiration, which we'll discuss at a different time. I tend to use what's called a 4-7-8 paced breathing when I do my manual treatment. And so, for instance, if we take a look at something like heart rate variability, and we take a look at treating the occiput and the low cervicals, which are linked to vagal afferents and to the phrenic nerve, when we do techniques at the base of the skull and we apply pressure in this area, I'll go ahead and ask the patient, take a big breath in for me. 1, 2, 3, 4. And as they fill their alveoli and stretch their alveoli, not only am I treating musculature and area that have direct connections to the vagus, but I'm getting afferent information from the alveoli in as well. When they breathe in, the muscles tighten and I can resist them. Now breathe out after they've held their breath for 7 more seconds or 7 more counts. Breathe on out, and as they breathe out to the count of 8, the tissues relax, and I can go ahead and add a little bit more compression up to the new barrier. I find that if they take in a big breath, 1, 2, 3, 4, hold it, 2, 3, 4, 5, 6, 7, blow it out against pursed lips, 2, 3, 4, 5, 6, 7, 8. 2 to 4 of these cycles of breathing is enough to make the techniques work here in the base of the skull for occipital inhibition and for condylar decompression. And we have done studies that have shown that using these techniques is capable of modulating heart rate variability. Heart rate variability is a biomarker for the relationship between the sympathetics and the parasympathetics. It's a relationship between the fast vagus and the slow vagus. Heart rate variability is a very healthy sign. And in dealing with dysautonomia in these chronic pain syndromes, using combinations of things like counter strain and breathing while we do the techniques are capable of moving us forward into taking care of chronic central pain syndromes and reducing inflammation. So that's my little webinar and hopefully a teaser about things that deal with using theory, using the evidence base that is evolving for manual medicine, and integrating those techniques into clinical goals.
No.
So thank you for your attention. Do you have any other questions, or guys, do you want to wrap up something for your March program?
Professor Kuchera.
Yes.
Simon had some technical problems, so I'll continue with you. First, thank you very, very much. It was amazing and very, very interesting. There was one question that was asked. Is this technique has a visceral application as well for releasing pain that comes from the viscera?
Yes, you can use abdominal techniques. When I do visceral techniques, I don't really think that I am doing things to flexures and sphincters in a biomechanical way. These sphincters and flexures are also innervated by and send information up through the unmyelinated vagus. And so from a polyvagal approach, visceral techniques, very useful. And it might be also of interest that the biome, the gut flora produces GABA, which is a inhibitory neurotransmitter, and that also sends its information up through the vagus. So yes, I think visceral techniques have some very good applications applying some of these new theories.
Thank you very much. It was really very, very interesting. We are all looking forward to see you in March in Israel.
I'm looking forward to coming and seeing you.
אוקיי, אז אני מודה שוב לפרופסור מייק קוצ'רה, שנתן לנו את המצגת המדהימה הזאת מארצות הברית. אני רוצה להזכיר שיש לנו עדיין מספר מקומות לקורסי דיקור יבש בסיסי, באוקטובר ונובמבר, אחד במכון הפיזיותרפיה בבית החולים אסף הרופא, ממש מספר מקומות אחרונים, וגם עוד כמה מקומות במכון הכאב ברמב"ם, גם כן קורס דיקור יבש בסיסי, וכמו כן יש לנו קורס דיקור יבש מתקדם של פלג גוף עליון בדצמבר 2018, גם כן במכון הכאב ברמב"ם. חשוב לי שתרשמו את התאריך, 20/2/2019, save the date לכנס השנתי של החברה הישראלית לרפואת שריר ושלד, לגעת בכאב 2019, תוכניה תפורסם ממש בקרוב, נפרסם את זה במידעון הקרוב, ואנחנו מזמינים את כולכם להירשם לסדנה שיעביר פרופסור מייקל קוצ'רה בתאריכים האלה, 27 עד 29 למרץ 2019, ב-31 במרץ עד 2 באפריל 2019, פה בישראל, סדנה שנתרגל חלק מהדברים שלמדנו היום בוובינר. אז שוב, תודה רבה לכולם, ואנחנו מחזירים אתכם לעיסוקכם הערב. לילה טוב מהחברה הישראלית לרפואת שריר ושלד. תודה.